We feel that lung cancer being the #1 cause of death and cancer mortality in the United States, we want to raise awareness in the community about November being the awareness month for lung cancer. And with the recent data in terms of screening and how that's going to change the recommendation in the future going forward in terms of screening the population who are at risk for lung cancer.
Good afternoon. My name is Dr. Owera. I'm with the Woodlands Oncology here. Welcome. You know, some familiar faces here. I don't know if anybody knows, but November is Lung Cancer Awareness Month. We all know about October and pink, but we like to do this presentation every November for lung cancer awareness. We feel that lung cancer doesn't get the publicity that breast cancer gets, and we hope we can change that. So having said that, we'll just go in and talk some statistics first. Very exciting news in lung cancer this year in terms of the screening that was updated, and we're going to touch on that toward the end. Very, very exciting news. So let's just start by providing some information and data about statistics. This is the mortality rate in 2011, and it really doesn't change every year. I would say over the last 5 to 10 years, maybe we start seeing cancer rate going up in terms of mortality and heart disease going down, not because people more die in cancer, just because we're living longer and getting cancer in general more. But if you take everybody, I mean, what do we die of? 28% of heart disease, that's still #1. 22% of cancer, that's 1 in 5. And I'm talking throughout life. The third cause would be strokes, is about 6%. COPD, about 5%. Accidents, about 4.5%. Diabetes complication, about 3%. Pneumonia, Alzheimer's, kidney disease, and infections. So as you can see, the top two still heart and cancer. This is again 2011. This is estimation cancer cases. In the United States, we diagnose roughly about 1.4 million cases of cancer every year. 1.4 million. That's excluding the basal cell cancer of the skin, which a lot of people are familiar with, okay? We don't want to hurt the dermatologist's feelings, but, you know, as an oncologist, we exclude the basal cell cancer from everything, except when they're metastasized, which is very rarely. So if you look at the data for the 1.4 million new cases, roughly, about 766,000 cases in men, about 678,000 in women. What's the most common cancer in men? Prostate cancer is 29%. That's about a third of cases. In women, 26% is breast cancer. So lung cancer ranked #2 as the second most common cause of new cancer in men and women, 15%. If you look at the statistics about 20 or 30 years ago, lung cancer was not as common in women. Okay? And the reason that is because women started to smoke later than men. Back in the 50s and 60s, that all cumulative risk of tobacco use. So if you look at the data in the 80s, lung cancer used to be more common in men than women. Now lung cancer is caught up in women in the last 20 years. So it's 15%. So if we keep going to the next slide, this is the estimated U.S. cancer deaths. So if you look at this is different than the previous slide. Lung cancer claims more lives in both men and women than combined breast, prostate, and colon together. So this is huge. I mean, we're talking incidence of 15%, but risk of death is 31%. And that's both in men and women, roughly. In men, colon cancer #2, prostate cancer #3, in women, breast #2, and colon in #3, and then it goes down to other cancers. So the conclusion is 2013 expectation is, according to statistics, of course, about 39,460 or about 40,000 cases, or women will unfortunately die of breast cancer, about 48,000 men and women colon cancer. Prostate cancer will claim the life of 33,000 men. Those are huge statistics. But look at lung cancer. I mean, you add those all together and it won't be the number of lives that we're going to lose to lung cancer this year. 160,000. This is every year. So if you look here again, this is just probably a repeated slide. How many cases of lung cancer we see every year? We see about 213 to 220,000 cases, and we lose about 160. So we're not doing a very good job. We're not doing a very good job. And the reason is because, unfortunately, with lung cancer, we're diagnosing the cancer when it's later in stage, okay? So the message is going to be, it's not what we can do after we diagnose the cancer, is what we can do before it gets to that stage. And, you know, in the 80s, when mammography became the standard of screening, you start seeing that drop in breast cancer incidence. Not because, you know, we knew how to treat breast cancer more, we did later on, but because we start catching it in early stage. And that's the whole message is, with lung cancer, we dropped the ball in terms of screening. And that's about to change. So if we look at the lung cancer, and generally speaking, we have two types of lung cancer. We call it small cell lung cancer. We call it non-small cell lung cancer. Small cell lung cancer is about 20% of all lung cancer, or 15 to 20%. Highly correlate with tobacco use. Non-small cell lung cancer is the majority, which is about 80%, and could be also related to environmental exposure, could be non-tobacco user. If you look at when do we diagnose lung cancer, I mean, if we ask about breast cancer, majority of women today, breast cancer get diagnosed in stage 1, or DCIS, which is stage 0 even. In lung cancer, in non-small cell, which is stage 4, 45% are already in stage 4 when we diagnose, and 25% already in stage 3. So you look at the stage 1 and stage 2, only 16.7%. In small cell, which is 2 stages pretty much, extensive stage, which is the equivalent of stage 4, is 62%, even worse. And limited stage, 37.6. So as you see, lung cancer, we diagnose it as later stages. The history of lung cancer, it was very uncommon until the 30s. If you look back in history, only less than 1,000 cases were reported in 1920. Now, whether that because lack of, you know, reporting or it's unknown, but what's already known is the tobacco use in the 30s and 40s and 50s have caused the spike in lung cancer that we saw in the 20th century and going on until 2013. And that was not, you know, the case back over 100 years ago. The first association with tobacco use was described by a famous CD surgeon, Dr. DeBakey, who's in Houston in 1942. And then over the years, people old enough probably will remember in 1960s when the first report of linking tobacco to lung cancer came out, and then they start doing the marketing on and limiting the tobacco and all that. So in 2013, what do we've got? 220,000 new cases still. Epidemiology, if you look at lung cancer, median age when we diagnose it is about 60. In the United States, the highest incidence we see, there's some little bit of racial, African-American, Hawaiian descent tend to have a higher risk of acquiring lung cancer if they smoke. Also, we look at it around geographically. There's a higher incidence in the northeast area, and then it goes down to the south coast where we live, the coast of Mexico, all the way from Texas to the Panhandle, Louisiana, Mississippi, all the way to Florida, to Tallahassee, all the way we get much higher incidence. If you look at the map, so we're pretty much here, and then you've got another spike in Tennessee, around Tennessee, where they call it tobacco land. So, but we're pretty much here in a higher incidence area. If you look at the etiology, the 3 most common causes of tobacco use, everybody, it's lung cancer, everybody knows what they are. If you know, people who smoked about a pack a year, you're increasing your fold about 20 times compared to non-smoker, which is huge. The data on secondhand smoking is, we know it could increase the risk. There's really no hardcore statistic data that you can trust, but approximately we estimate about 3,000 cases, patients die of secondhand smoking because of lung cancer. This is very important. 10 to 15% of people who had lung cancer have never smoked. And people don't know that. I mean, there's this thing that you've got lung cancer, you must have smoked all your life. It's not true. I mean, 10 to 15%. So roughly about 1 in 10 or 1 in 8 patients that we see have never smoked. Okay? In terms of the increased risk, we know there are 30% increased risk individuals who live with a smoker compared to non-smoker. There's some occupational risk that probably people are familiar with. There's some radiation risk that we know of. Just moving on very quickly here, signs and symptoms. We're not going to spend a lot of time with this, but how do people present with lung cancer? Systemic symptoms, weight loss, fatigue, weakness, those are all non-specific. And then you got the localized symptoms, persistent cough, shortness of breath, coughing up blood or hemoptysis. Sometimes we see people in the hospital with pneumonia that turn up when we do scans to be a lung cancer. Pleural effusion, hoarseness, which has changed the voice, difficulty swallowing. Some people will show up with what's called SVC syndrome, where they have a very huge tumor pressing on the veins and cause facial swelling and wheezing. So there's a variety of things that we see. That's not the focus of our talk. Our talk is not to get to that point or catch it early enough to where we diagnose it before they have symptoms, when they're asymptomatic, and that's the point. So what is the prognosis based on? Again, stage. You catch it early, you've got a better prognosis. You catch it when it's stage 4, unfortunately, your treatment is just to slow it down. Age, we know younger patients do better. Performance status, even more important than age. What kind of shape you're in? We get people in their 70s and they're acting that they're 45 and vice versa. So the performance status is very important. What we call comorbidities, what other medical problems they have. Molecular prognostic factors, this is more a new field in the last few years. As an oncologist, we know what to check for in terms of the biology of the disease. There are certain cancers that have certain mutations that act more aggressively, and there are some mutations that tend to act more indolent and slower growth. If you look at the stage, this is very quick again. There are 4 stages of lung cancer, as most people are aware. Stage 1 or 1A, we see just a very small tumor here. We call it T1, tend to be less than 2 centimeter. N0, that means no lymph node. M0, no metastatic disease. As you go down, stage 1B, this tend to be a little bigger, but still no lymph nodes. Stage 2 tend to be even, stage 1B tend to be bigger. And then when we go to stage 2, you start seeing some lymph nodes involvement. Stage 2A, stage 2B. Stage 3, when the lymph nodes goes inside the chest in the mediastinum and hilar. And then stage 4, when unfortunately spread to other organs. So again, very quickly on the treatment, we're not going to spend a lot of time. When we catch it early on, stage 1A, we just ask the surgeon to take it out. We don't give any chemo, we don't give any radiation. In stage 1B, may not give chemo, depends on other molecular factors. Stage 2A, stage 2B, we always recommend chemo because of the risk of metastatic disease. When we move on to stage 3A, it's probably the most complicated stage to treat because we have to treat them with chemoradiation up front, try to shrink down the tumor, and if we're lucky, we shrink it enough to where surgery will become an option. Okay? And then stage 3B, mostly chemotherapy, occasionally we use radiation. Stage 4, it's chemotherapy to slow down the disease. Unfortunately, with stage 4, there's no cure usually. We have a lot of new treatment. We can always come up and use different type of chemotherapies, but there's no absolute cure. So the prognosis, if we catch it in early stage, 5-year survival. Well, I mean, say 5-year survival, that means you're alive in 5 years, which means you already beat the cancer. It's about 60 to 70% in stage 1. It's not that high, but definitely much better than stage 4. Okay, it's not that high when we compare it to breast cancer, because breast cancer in stage 1, women still have excellent prognosis, over 90–95%. But what we like to do, what we like to see as an oncologist and medical community, we like to see more shift of diagnosing the patients up an earlier stage and less of this later stage. So how do we do that? Screening. This screening started back in the 70s, and back then it was basic chest x-ray that they've tried. And then they tried something we call sputum cytology, which you take the sputum and you check for cancer cells. And that didn't work out very well. A lot of cancer cases were missed and did not prove to be beneficiary. Another chest x-ray screening study came in from Eastern Europe. that one showed possibly increased diagnosis of early stage lung cancer when you get everybody with chest x-ray, which started some spark interest in getting more screening. It was one of the only positive studies of chest x-ray, but still missed a lot of lung cancer. And the problem is when you use just chest x-ray and you screen, that's right, it could be better than nothing, and you could catch few, but it's not as good as CT scan, and what it could cause what we call false hope, meaning patient will get a chest x-ray and think that they fine. And that could unfortunately encourage more smoking in some people. So, we don't recommend chest x-ray screening for lung cancer today. You could get chest x-ray for people who have COPD. If you don't have CT scan, it's better than nothing, but it's not recommended. But that's quite interesting here. There was a Japanese study that looked at chest x-ray again, and they start seeing that if they screen, not everybody, if they just screen heavy smokers with chest x-ray, they start getting better results. But then the study of the lung cancer, screening lung cancer with CT scan came in initially in Japan, and then that led to this study. This is the major study that we're going to talk about tonight. This came out in last year. It was a very large study, over 50,000 people that were enrolled. This was done by the National Cancer Institute, the NCI. So this is pretty much the standard for research in the United States. This is a government-run cancer research. They took about over 50,000 people all across the country, different groups, and the only criteria to screen those people were a history of smoking, and they have to fall in certain age. So they took patients between age 55 to 74, thinking that the median is about 60. And they enrolled patients who have smoked at least 1 pack of cigarettes a day for 30 years, or 2 packs of cigarettes a day for 15 years. And that's what we call 30-pack year history. You multiply, either 1 pack a year for 30 or 2 for 15. So they took those patients and they screened them with what we call low-dose CT scan. What's low-dose CT scan? Less radiation than the standard CT scan. And that's important because if you're going to keep screening those patients every year, you don't want them to, die of lymphoma from radiation down the road. Okay, so with low-dose CT scan or standard chest x-ray, they did x-rays too. And this study took years to complete, but the results came out last year in 2013. And they found that when we screen individuals in that category, in that risk category, we were able to reduce the risk of lung cancer death by 20% when they compared the CT scan to the chest x-ray. Okay? When they had the chest x-ray compared to the general population, the reduction was not significant. So the conclusion of this was if we screen everybody between age 55 to 74 with low-dose CT scan, roughly you're estimating about 8 million people in the United States that will be filling that criteria. Okay? You could save about 4,000 lives a year. Okay? Now, it depends on how you look at it. If you're an insurance company, you might not like this stats because you have to do a lot of screening. Okay? If you look at it from preventive and from public health standpoint, this is even more impressive than the mammography in women, if you look at the data. Okay? 4,000 cases, 4,000 deaths every year, it adds up. That's a lot of lives that could be saved. Of course, the criteria again, they're not telling you to screen everybody. They say you have to be between age 55 to 74 according to this study. Okay? Smoking history 30-pack year, and chest x-ray is a no-no. So this came out last year from the NCI. So the next step was for the U.S. Preventive Service Task Force, which pretty much is the government agency that tells you what screening is good for you and what's not. Okay? And as oncologists, as physicians, we often disagree with a lot of things that these guys say. You know, one of them was think about not doing PSA for women routinely, which the urologists don't like because that's going to move prostate cancer from being detected in the earlier stage to being detected in metastatic stage. Okay. One other recommendation that they made a couple of years ago, which was a little bit goofy, is doing a mammography every other year instead of yearly. And I'll tell you, there's not a single physician oncologist in practice that will advise women not to get an annual mammography. Having said all that, and having know how these guys want you to do less than more, they came out with a recommendation in July the 29th. It took them about a year and 1 month to study this NCI trial. And they said, we recommend CT scan screening for long-term smokers. Okay? So this is huge. The decision is a major step. This is going to be accepted standard of care going forward, like the mammography, like the screening colonoscopy. They went further. They looked at the data and they found even men that are 74 to 79 had benefit from the screening or could benefit from screening. So in the NCI was 55 to 74, and the U.S. Preventive Task Force, they said the recommendation now 55 to 79. If you fall in that age, men or women, and you have smoked 30-pack in your life, 30-pack year, and you will be eligible. If you quit more than 15 years ago, you don't need to be screened. Okay? Simple reason, you make the math. Because you can't smoke 30-pack year if you probably quit more than 15 years ago and fall in that group. Because you're 55 and you smoked 30-pack year. If you quit 15 years ago, that means we quit when you're 40. You couldn't start at age 10. Not 10. That's true. I mean, there's some people that started that age. Back then it was...
Does that mean those people are out of the woods?
Not out of the woods, but statistically, they're not going to recommend it to screen. No, your risk of smoke, if you smoked, your risk of lung cancer always there. But statistically speak, once you hit the 15 years, the risk goes down almost, instead of 20-fold the normal average citizen, you're probably about 1.5 or 2-fold. So not that high, significantly, if you quit 10 to 15 years, okay? So after 15 years, they don't want people to start getting screened. They're not going to pay for it, basically, when it gets paid for.
How expensive is the screening?
That's a good question. Depends where you go. Right here at the Woodlands, I think, what's the rate?
Right now, during the month of November, it's $174, and you get a visit with a nurse.
It is very cheap. I mean, it's very cheap. When I heard the price, I was surprised how cheap it is. If you go to a hospital and hospital fee, they probably multiply that by about 10 or 20 times, you know, adding in all this facility fee and hospital fee. Most independent groups now are offering, you know, rate in probably around the $300-400. You know, our rates tend to be competitive, just trying to raise awareness here. This is still not being paid by the hospital, by the insurance, but we're going to go to the next slide and show you what's going to happen next. So this very, very strong statement came out just a couple of months ago, basically, end of July. What's next is the U.S. Preventive Task Force, when they show out the statement, they will give about 60 days period for what they call it, public comments, basically. They accept all comments and they have to give that grace period. And then the next step, this will go to the Medicare, because they pretty much define this recommendation as grade B. And what does grade B means? If you have a recommendation from this U.S. Preventive Task Force as grade A or grade B, then it automatically has to be covered by Medicare and private insurance. And this was actually one of the good things about the Affordable Care Act, if there is. Oh, I'm on camera now. I'm on record. I can't say anything. So I'm trying to use my words here, okay?
You did good.
So, all right. So, even if it wasn't, starting 2014, it will be the law. If given grade B, they cannot provide coverage. So, any day now, between now until the end of the year, we're expecting Medicare to come up with an announcement, and that will be, of course, followed by all the private insurance, not because they have an option, but they have to do it, that they will cover this as screening. And that, I think, is going to change the landscape in lung cancer. So the final decision is pending. This was endorsed by the American College of Physicians, by the American College of Chest Physician, ASCO, which is our community, the American Society of Clinical Oncology, and the National Comprehensive Cancer Network, and then there's a long list of other organizations that endorse this. So, thank you. Thank you. Well, thanks for coming.